Okay, well, I've hoped the conference has been really wonderful. I've heard good things from many people, and including the people from my group. I'm going to talk about lifelong restoration. I really believe that rehabilitation is changing from social rehabilitation to lifelong restoration through regeneration, and that's happening today. So I'd first like to dedicate this talk to my good friends, Christopher Reeve and Dana Reeve, who you all know passed away recently. You might remember this video a long time ago, and it shows the changes. Is the sound working? Yeah. But let me explain I don't know how many of you remember seeing this video during the Super Bowl 6 to 8 years ago. It's a 30-second video. And it raised a huge commotion in the field of rehabilitation. Okay, you'll see basically what it shows is Christopher Reeve standing up and walking, and it looks real. And if you understand Chris, his intent was exactly that. If people could visualize that it's doable, it is doable. Oh well, just let it play. So basically, this guy's saying that amazing things are happening. Breakthroughs in cancer, spinal cord injury regeneration. And tonight, I have some very special guests. And this is what confused people. I think people that didn't understand the language, or it's like as if this was turned off, it looks like he recovered. This was very shortly after his injury, a year or two. And, he did this a number of times, and it works. He did it for a very specific reason. It caused him trouble, but it worked, okay? Because now people believe that recovery is becoming doable. For example, our center is the first center. Can we advance to the next one? Oh, there we go. Oh, let me first disclose that I'm required to do this, that I have multiple patents through Washington University regarding FES. And I have financial interest in a company that we started in order to actually carry out clinical trials. If you remember the other two talks I've given here in the past. But that's all under management of the Hopkins conflict of interest. Anyways, today I'd like to talk about these categories of things. One, that there is hope today for recovery for most everyone with a neurologic injury, no matter how long you are out from your injury. Our center, the International Center for Spinal Cord Injury, is the first center that's dedicated to people living with paralysis. Rehabilitation is exclusively associated with acute phase of injury. There is no rehabilitation really available for people living with injury, okay? So this has really taken off, because it works. We believe that we can optimize recovery of function today through a number of different factors, and we'll talk about that. We'll talk about the problem of spinal cord injury, but I want to emphasize that these types of approaches, regeneration and restoration of function, the approaches are going to be the same for all disorders of the nervous system. It doesn't matter whether it's Alzheimer's, Parkinson's disease, stroke, brain injury, spinal cord injury, TM, it doesn't matter. Although they have different mechanisms of injury, the end result is identical. The same cells are lost. The same problems exist. The same, things need to be adjusted. So we'll talk about that. We'll look at the different approaches to regeneration and what people are doing today. We'll talk about transplantation just very briefly, really emphasizing that there's multiple mechanisms responsible for what's going on. And then, is it possible to create an organ like a nervous system? Okay, recovery of function. It is possible long after an injury. So, if one thing Christopher Reeve demonstrated was that recovery of function is possible in a worst-case scenario long after an injury, substantial recovery of function. Doesn't say why it occurred, but then we'll focus on activity-based restoration therapies, and we'll go through this. But I want to emphasize that there's common goals and mechanisms for both regeneration and this activity-based restoration therapy. Whether you transplant cells or use activity-based restoration therapies, they're working through the exact same mechanisms, and you'll understand that when we get done. So the center is here at Hopkins and the Kennedy Krieger Institute. Is dedicated to people living with paralysis. We have a sub-focus on pediatric spinal cord injury. So we take care of small children all the way through from the onset of injury through lifelong care. Because for small children, there's really no adequate rehabilitation center in the world. It's just too infrequent. But the program designs an individualized, lifelong, in-home restoration therapy rehabilitation program. The only way anybody can carry things out for long periods of time are by doing it at home. There's just simply not enough centers in enough places, and the information takes years to get out there. This is doable. So the vision of the center is to provide meaningful recovery and life improvement for every person with paralysis. This is doable. It doesn't say cure, but meaningful. What's our mission? Well, we're transitioning today's science to near-term therapeutic applications. So we're interested in, although we do stem cell transplantation and other things, we're very interested in what can we do in less than 7 years that doesn't require going through all the steps of the FDA. The International Center will develop and apply advanced rehabilitation and restoration strategies for optimizing spontaneous recovery in those living with paralysis. So even our research is focused on chronic injury. So here's the problem. This is a T2-weighted MRI image of someone who had a cervical spinal cord injury from a trauma some 20-odd years ago. But as many of you know who have TM will look identical, or it can be longer, but it doesn't matter. The end result is the same. Whether you have TM or a trauma to the cord swells, you get a secondary infarct, the cord dies from the inside out, and you're left with a donut-like ring like this. What's important is at the outer edge of the cord is what's critical. That's what carries the fibers to and from the body. You can lose the entire middle piece here and have normal function. This person, although completely paralyzed for years, now can do triathlons. So this proves we don't need to cure the nervous system. We don't even need to come close. Just like in animals, 10% of connections is probably enough for people to run and walk. So, last time I was here, I showed this slide, that typically a severe, complete, or A spinal cord injury has a poor prognosis. This is absolutely wrong. Absolutely wrong, okay? And I'll show you. This data, it was correct in its day. But if you only do what they say, this will be correct. But this doesn't need to be correct. In today's world, this no longer is true. So what's different about this person? Because you could put up 9 MRIs just like this, and those people are sitting in wheelchairs. Well, we now have advanced techniques, and you've heard some of these talks about diffusion tensor imaging, where we can actually visualize the tracks. So in this section, here's the dorsal columns and the lateral columns. We can actually get an index of the percentage of axons that cross this lesion, and it's about 10%. So here's a person who can run and walk and only has 10% of the connections across that lesion, exactly like the animal data suggested. So the animal models aren't as far off as people believe. So here's a vertical image. You can really see this dramatic reduction in the number of connections. So again, at any single level or 2 levels, you can lose the entire middle part of your spinal cord and have normal function. That's because those neurons that go out at that level come from at least 3 levels through each nerve root. Each muscle has contributions from at least 3 root levels. So there's no possible way that loss of the inner part of the gray matter at 1 to 2 levels can cause substantial loss of function. Okay, here's the problem. The outer part is the white matter, this inner part's gray matter. Here's the end result with trauma to the nervous system, or stroke, or infection, or whatever you want. This is missing. A big goal used to be to try to fill this gap. We now understand that there's plenty of tissue out here that we don't need to bridge this gap anymore. But a big problem is this scar, okay? It's a scar for several reasons, because it expresses chemicals, and it's also a physical scar. It's literally rubbery. These broken connections are trying to constantly regrow. They're encountering signals that say stop, turn around, go back the other way. It's as if you rearrange the roadmap signs. So scientists are using enzymes to dissolve these. They're using multiple molecular approaches to overcome this or to inhibit its development. We also believe that this is not critical, this barrier, because this is not a problem out here. Okay, we can get by this. Now, there are connections that exist across the lesion, like this one, that aren't functioning properly because they're missing these little hot dogs, insulation, you know. So the electricity comes down and it short circuits. So this is what happens in TM or MS. There are many connections that exist across the lesion. Even though you're called Asia A or complete, you probably have about 3 to 5% of connections across the lesion that are functioning, but they're not really useful. So scientists are trying to promote remyelination. This can be done either through transplantation to stimulate endogenous stem cells or to directly supply those cells or deliver growth factors. Delivery of growth factors is another important goal to try to coax these across these inhibitory barriers. Okay? What I'd like to emphasize is every single one of these mechanisms that I just talked about is highly activity dependent. We can release brain-derived neurotrophic factor, you know, microscopically exactly where it should go through neural activity. We, you know, can stimulate oligodendrocyte myelination through activity. A lot of this is occurring, and we're hypothesizing, in chronic injury because of loss of activity. These neural circuits need to be active. It's as if the phone wires need to be working, otherwise that phone slowly doesn't work, okay? And we know this for a number of different reasons. So we talked about a number of different strategies, some of which that are very, very difficult. You know, I think a number of us here are focusing on the more doable strategies. I know our group is, and you know, certainly Doug's group is. But probably the simplest thing, and this is an absolute requirement, is that we need to optimize spontaneous regeneration. There will be no cure for people that don't optimize their own physical health and functional recovery. Absolutely. Doing a transplant into a nervous system that's been slowly debilitated because of loss of activity is like, you know, throwing those cells in the wind. You know, it's amazing we've gotten positive effects, and we have. That's the promising thing. You know, amazing things have already happened, and we're doing it under suboptimal conditions. Let's do them under optimal conditions. So years ago, in '99, we showed that transplantation of ES-derived progenitor cells can produce behavioral recovery. You know, the difference was like this. You'll see this is an animal 6 weeks after injury. He can drag his behind, drag his legs. It's a BBB score of 8. Here's a sister animal with an ESL transplant, again 6 weeks later, only 2 points better on the scale, but you'll see a big difference. This animal can step walk. You know, it's very, very important. This was a traumatic-induced injury model. This was so long ago that we didn't have markers. We didn't know what the cells were doing. What we saw is that the cells were causing myelination, and we speculated that it was that. But in addition, the many neurons that grow from these cells send axons all the way up and down the cord. They grow a centimeter in a week in white matter, not gray matter. In fact, these axons prefer to grow in white matter, not gray matter. Just the opposite of what scientists say. Scientists say, oh, they shouldn't grow in white matter because that's inhibitory. Well, not to these cells. But now we know that stem cells have many functions other than simply replacing cells that are lost. They can replace neurons, they can remyelinate, they can form chimeric blood vessels. They're a huge growth factor production and delivery system. They reduce and interact with the inflammatory response. They break down inhibitors in the glial scar through enzymatic mechanisms and phagocytosis. So there's many mechanisms that contribute to recovery. And we don't know which ones are most important, but probably multiple ones are important. Now, is it possible to create an organ? Absolutely. They've already shown one of the critical factors, and this has happened with ESLs, is that you can produce organogenesis in the pancreas and liver by critical events that occur between formation of blood vessels and formation of the organ. So can you do the same thing in the nervous system? No one's been able to do this, or I don't know if people have really tried. You know, we can get nervous system to grow, to connect, to appear to function appropriately, but it doesn't look like the normal nervous system. It doesn't form all the complex things that the normal nervous system does. Is that really doable? I think it is in the CNS. And I think the same factors are involved. We stumbled across something years ago. These ES cells make embryoid bodies. It's an amazing little thing. They make these little embryoid bodies spontaneously, and they have little neural tube-like structures in them. These things are almost identical to neural tubes that occur during normal development, and they're just doing this on their own. These cells will spontaneously make neurons, form circuits in culture. The oligodendrocytes will function appropriately in culture. They'll myelinate multiple segments of different axons. But here's a study where we actually make what I believe is chimeric nervous system. This tissue is indistinguishable at the light and EM level from immature nervous system. Okay? So basically, these are normal animals where we inject the cells as small clumps in the space around the spinal cord, and then we wait 4 months. What we see is the graft grows outside of the spinal cord. This is all the graft, okay, out here. This is staining for astrocytes. This is the normal cord. This is the graft. This is staining for neurons, normal cord, graft. This is staining for myelin, normal cord, graft. Notice in the normal cord, most of the myelin's on the outside. Notice in the graft, most of the myelin's on the outside. It's really amazing. These are the nerve roots going down these open spaces. We form all the principal neural cell types in this tissue that are found in the cord. You don't find neurons that aren't found in the cord. It's amazing without us instructing them, right? They make motor neurons. These motor neurons go out to muscle. There's sensory cells that go into the cord. The most amazing thing is this thing's vascularized, and it connects to the host nervous system. How does it do that? It doesn't do it like a tumor, where it attracts the host in. It makes its own endothelial cells. A critical factor is that 4% of the progenitor cells that we transplant are endothelial precursors. If you remove those precursors, you don't get this effect. And that fits with the data from the pancreas and the liver, where you can't get organogenesis if you remove the angiogenic cells. So maybe those are critical factors. This is EM through the graft on the outside of the cord. These are normal synapses. This is really for the scientists. Now, these are pictures of the outside of the cord and the outside of the graft, stained for astrocytes. They make the kind of steel of the building. Can you tell the difference between the steel of those two buildings? They're almost identical. Look at that amazing structure. These cells have come together, auto-organized, formed all the principal cell types in the nervous system and organized. So this is the transplant, and that's the normal cord. So people that study this could tell the difference, but it's subtle. Now, this is a normal basal lamina, but this isn't on the cord. This is on the outer graft. Okay, this is a very complex structure that surrounds the nervous system. It's called a blood-brain barrier. Here's the normal cord with the increased myelination on the outside, and the gray matter on the inside. Here's the graft. The red is the myelination, so it's mainly on the outside. Here's the myelination, a higher power picture of this. Look at all that myelin. Normally, just all wrapping axons in a normal way. And most of these axons are from the graft as well. This is EM through this. This is an ES-derived oligodendrocyte in the graft, myelinating axons that are passing. The majority of these axons, 90%, are from the graft, not the host. So they're myelinating their own axons appropriately. If anyone were to look at this who's an expert in EM, they'd say this is immature nervous system tissue. This is amazing. This is the interface between the central nervous system and the peripheral nervous system. So every time a root comes out from the spinal cord, you have this interface. This is central myelin, called myelin from an oligodendrocyte. This is peripheral myelin from a Schwann cell. This is collagen, which is only found in the peripheral nervous system. This is indistinguishable from an immature interface in the normal nervous system when you show it to experts. Here's an endothelial cell. The graft is completely vascularized. The blood cells are from the host, but these endothelial cells, over 90% are all from the ES cell derived, and it turns out to what we believe is a critical factor. Anyhow, I'm going to stop there and switch gears to this activity-based stuff, but I just want to say it's such an exciting time. You know, Doug's recent results are really amazing. I think the model that he used is a very challenging one. It's one that actually I think is a very good model because normal disease is not a single hit problem. You get a bit of a continuing loss. And to show the results that he did is really amazing. So I think, you know, short of President Bush, we'd really be moving. So anyways, here's the hypothesis. that neural activity is critical to the nervous system. Important to maintain itself, but also to support regeneration, recovery function, or any curative treatment. To enhance regeneration, we need increased neural activity. Normally, you're up here. After an injury, you're way down here. Below the level of the injury, activity is so dramatically reduced. This has been shown in multiple studies, okay? If you reduce activity in the developing nervous system to the same degree, you completely impair development. All those mechanisms in development, cell birth, survival, migration, pathfinding, fate choice, myelination, are all dependent on activity. They all get blocked by reducing activity during normal development. Well, they're probably going to get blocked by decreased activity in the normal nervous system. You know, we used to believe the nervous system didn't turn over. The nervous system now, you know, we're seeing that glial cells turn over. Replacement of oligodendrocytes is now an important thing. What if replacement's important to be regulated by activity? And it is. We already know this. So we just went through this. All these are regulated by activity. So how do we get down from here to here? We can simulate this in the lab, of course. We can do spinal cord injuries, add FES with the prediction we're going to enhance regeneration. We could use drugs that inhibit activity, such as baclofen, which is a commonly used drug. What if we haven't been doing the right thing all this time? What if we've been inhibiting spontaneous recovery of function? Well, the answer is probably we have. But I'll show you that FES can dramatically enhance regeneration, and baclofen can dramatically impair regeneration and recovery of function. Measuring indices, cell birth migration, myelination, and formation of new circuits. I'll go through this really quickly. Basically, we did multiple models using FES with traumatic spinal cord injury, measuring new cell birth, proliferation, and myelination. If you add FES, you get enhanced cell birth, survival, selected to the area that's stimulated. So it's only that area that receives the increased activity that had decreased activity. Adding more activity to a normal area doesn't further increase activity. It also enhances neural differentiation. So you shift differentiation from these progenitor cells, from oligodendrocytes and astrocytes to neurons. One of the reasons that neurons aren't born in the cord all the time, particularly in the injured cord, is because activity is so dramatically reduced. You can really dramatically enhance oligodendrocyte myelination by activity. Now, the converse is even worse. So let's do the same model, but now let's give clinically relevant drugs, clinically relevant concentrations of baclofen, using the same standards we would use clinically. Let's begin it, you know, in the first month and, you know, slowly increase it. So we showed that you can dramatically impair recovery. Remember I showed you that 2-point improvement with ESL transplantation? Well, this is like an 8-point loss of function, and it's permanent, relatively permanent. I mean, if you stop the baclofen, it's not that the baclofen is just sedating the animal. You stop the baclofen and it stays down. If you take chronically injured animals, okay, and then start treating them with baclofen, they lose function. If you stop the baclofen, that loss of function stays down. So it doesn't matter whether you get it early or late. It's not necessarily a good thing. An oral baclofen is basically not very effective, okay? Activity is a better treatment of spasticity than any medication. We can reduce your spasticity through activity better than any medication. Now, the intrathecal pumps are a very important piece. Anyhow, let's move on. How do we do this in humans? Well, I think a lot of you have seen this FES bike system. I've talked about this as a theoretical idea at the last meeting. It's actually here now. We can actually stimulate these muscles using a small computerized controlled system, talks to a motorized system here. So this all works by itself. It can go in the home. You can wheel up to it, strap yourself on. We can recognize what's going on. We can change the program. It's automated to take you from that early phase where your muscles are weak to the strong phase. It's all automated. It's super simple. Here's the concept. The cycling motion, the stimulation of these muscles, the contraction of these muscles produces pattern neural activation that goes up and activates this pattern generator. That sends volleys of activity up the spinal cord. And they stop at the injury zone. So this is a person with a cervical injury. But what happens over time is that increased activity actually stimulates regeneration. It stimulates axonal outgrowth, but it really stimulates remyelination of those connections that already exist across the lesion but aren't functioning properly. So we believe that's a critical factor. But it also releases growth factors. It does all these things. And it does it in largely the appropriate way, and in a way where we don't have to spend 10 years going through the FDA. But one very important reason is, the benefits of exercise are so well proven for reduction of cardiovascular, for everything. Why don't we offer exercise to people with paralysis? I mean, that's ridiculous. Well, how can you exercise somebody who's paralyzed? They can't move. Well, you can now with FES, okay? But it required moving it out of a center and putting it into a home, making it doable, because time is the critical issue. Nobody has time to go down to a center 3 times a week. So it is possible. I think everyone understands the benefits of exercise, increasing muscle mass, maintaining bone density, enhanced blood flow, decreasing complications that are frequent in this population. But I want to focus on this. This is reason enough to do what I'm talking about, just the exercise. That's reason enough, okay, and cost-effective enough, because that's what your cost savings is going to be. But we can get this at the same time. We can decrease spasticity and enhance regeneration and recovery of function, we believe. Now, everyone remembers the case of Christopher Reeve. I don't want to go through all this, but he didn't really recover anything in his first 5 years. He went from 0 motor function to 20% of normal in years 5 through 8. He recovered from 7% of normal sensory function to 70% normal sensory function in those 3 years. He enhanced his physical body fitness. Tenfold reduction in use of infections and use of antibiotics. Reduced major medical complications, improved quality, and gave him hope to live. So this was really what stimulated this whole area. Here's a guy that had no hope and no chance, and here he was really on a road to recovery from in a real worst-case scenario injury. It just simply said that delayed recovery is possible in substantial recovery. Okay, now we didn't know what was going on there, but we had a pretty good idea. So we started designing some other studies, and I'm not going to go through all these details, but this is a cohort study. It's a prospective cohort analysis where we looked at the role of the FES bike, 3 hours of FES biking a week. Okay, what are the benefits? The physical benefits are huge. Here's a normal spinal cord injury, a section through the leg. The muscle shrinks, the fat grows. The size of the leg stays the same. Here's a normal leg. Here's the muscle, there's the bone, this is the fat. So the muscle shrinks, the fat increases. The loss of muscle causes early diabetes. The increased fat causes reduction of HDLs and enhanced cardiovascular function. If you reverse those complications. That's already been shown. Well, this is easily reversed in a couple months of FES cycling. Okay, we can reduce fat in half and double muscle mass, and this is in a 60-patient population. But more importantly, the same degree of recovery that Christopher Reeve had, we can achieve in years with the FES bike. 70% of people that use this bike recovered major neurologic function, even though in the study, no one could be enrolled in the study unless they were more than 2 years out from their injury. These were all chronic injuries. In the control group, on average, they lost function. Okay? So even the 30% of people in the RT group that didn't gain function, at least they didn't lose function. And in addition, they had all these physical benefits. But of the 70% that did recover function, they improved 40 points on their ASIA scale. 40 points, that's huge. That's giant. That's more than methylprednisolone does in acute injury treatment, just to give you relevance. Currently we have no treatment for really any neurologic disease in a chronic period. This is really going to become one of the first. So in this study, just as a summary, in the control group, most people lose function on an average of about 11 points. This is measurable function over a period of 3 years. 100% of people in the RT group benefited. They benefited physically, reducing complications. We also could double that muscle mass, but simultaneously reduce spasticity. Other benefits, this was interesting. 50% of people in the RT group were able to discontinue use of baclofen. So half the people could completely come off baclofen. 90% of the people were able to reduce baclofen or change from polytherapy to monotherapy for management of spasticity. We had significant improvements in the functional independent measures, and using the gold standard Asia Motor Sensory Score, there was a 70% responder rate on average, recovering about 40 points of neurologic function. 30% did not recover function. These are probably the most severe category. I just want to emphasize that the people in this study were the more severely injured people, not the less severely. These are the ASIA A, Bs, and Cs, no Ds and Es. These are the people that, 3/4 of the people were ASIA A or complete on both sides, okay? So these are complete people recovering major neurologic function. So in summary, we're able to reverse physical deterioration, enhance muscle volume and strength while reducing spasticity. We can reduce baclofen dosage, and this is an important goal. We can reduce complications, get functional gains, and get recovery of neurologic function. So our real goal now is to try to understand the molecular mechanisms of this and optimize this. So let's maximize the physical integrity benefits, but let's do it in a way where we maximize what we know from animals stimulates regeneration and recovery of function, okay? Because, of course, in humans, it's difficult to measure regeneration. We can measure recovery of function. But I think, most people do believe to recover major neurologic function, if you're ASIA A or complete, you have to have some regeneration. So in summary, I think there really is hope today, okay? And this is just the fact. The old days of waking up with an injury and having someone telling you have a bad spinal cord injury and life is over, get used to a wheelchair, that person should be shot. Okay, because that's absolutely wrong. Remember that 97% of people recover function. So why tell them? What's the psychological benefit of telling them they're not going to recover? Okay, so those are old days. But it takes time for things to change, Doug's a leader in this, and he's changed a long time ago, like I did. But it's still changing. We talked about the problem and approaches to regeneration, and I think you've heard a lot about different approaches to regeneration. And the MS field is much further ahead, I think, than a lot of other areas in neurologic disease, particularly in clinical trials. We talked about transplantation. Doug will really spend a lot of time talking about this. We talked about recovery of function, how it is possible long after an injury. We talked about ABRT, how the goal is to optimize spontaneous regeneration and recovery of function, promote substantial recovery in a chronic injury, maximize physical integrity of the body at the same time, and the concept that it's applicable to all disorders of the CNS that involve immobility. If you have immobility, you have inactivity, you have decreased neural activity, okay? So these are useful. I mean, anybody that doesn't walk appropriately can get more efficient exercise, right? And not get all the wear and tear on their body. So now I didn't talk about all the methods that we use for ABRT. I want you to understand the FES bike is the most effective and efficient first step in ABRT. Okay, but if you come to our clinic, you'll see it's a tenth of ABRT. We use the same concepts all over the body. The FES bike is just very efficient because it's been designed to do this and go in the home. I wish I had systems to do the rest, because it would make our jobs a lot easier. But we're working hard to develop lifelong in-home programs that people can just simply do at home. And Doug's been a huge partner in this. And then finally, we talked about that there's common goals and mechanisms between regeneration and ABRT. They're basically working through a common funnel. And therefore, you might suspect synergy. So, I'd be very interested in combining what we're doing with what Doug's doing. Because if he got that good of an effect, we'll really rocket him. So this is just hope in many languages. I think hope is just critical. If you remove hope, what do you got left? Everybody has hope, trust me. But you gotta work. Now, what I'm telling you is that if you come to our new program, the extent of recovery that we're getting here, that I showed you in that study over 3 years, we're now getting in 3 months. We're doing it because we're doing a more intensive startup phase and then sending him home, and we're adding other pieces. So I was amazed at this when we first started looking at the data about 5 months ago, because it was just recently that I moved here. And, it's just, the therapists get better, and we're really getting good at doing these things. So it's really realistic. It's realistic for the majority of individuals, but there's no reason for anyone not to do this because of the physical benefits. and insurance pays for it. So there's a ray of sunshine, and it's not just Doug. No, Doug. Anyways, I'd really like to thank Doug. You know, he's been a great colleague and friend, and you know, there's very few of us that like to cross all these barriers between basic science, clinical trials, and Doug and I share that same space and passion. So I love speaking at this meeting, and I just like knowing him too. Thanks.